Hi everyone, welcome. My name is Susila Japagai. It's great to have you all here. Today we are diving into something we deal with all the time on the floor, accessing pain of our residents with dementia and delirium. Did you know that about 50% of people living with dementia actually suffer from chronic pain? I want you to make sure to keep things super open today. This is a safe space, so please don't be afraid to ask questions or share time you have struggled with this on the word. We are going to build on what you already know from uni, but focus heavily on practical skills, specifically reading on nonverbal cues. So, what are the real hurdles here? Well, you have probably noticed that residents with advanced dementia cannot always just point and say it hurts here. Because of their confusion and hesitation, it's really easy for us to make mistake their pain for just another behavioral or psychological symptom of their dementia or BPSD. Many nurses actually report feeling they haven't had enough formal training on these. Unfortunately, this means our residents are in danger of silently suffering and are given sedative or antipsychotic. But they really need is just some basic pain relief. Just let's talk about how to catch these clinical challenges. Mm, it's basically a vicious cycle. Pain and delirium often show up together. When a resident is in acute pain, their body gets super stressed, releasing hormones and triggering inflammation that can actually push them straight to delirium. Um, if we miss the signs of pain, the resident just get more and more confused, and treating them becomes so much harder. If we can catch the pain early, we can often stop the delirium from getting worse. Normally, we'd ask patients to rate their pain from 1 to 10 on numerical rating scale, right? That's a gold standard. While some patients with mild dementia can still manage that, our delirious or severe dementia patients simply cannot. We need to completely shift our mindset from asking questions uh, to start relying entirely on our observation skills. We have got to look at their body language, listen to their vocalizations, and even get caregiver reports to figure out what's going on. This brings us to a PAINAD scale. It has gained massive popularity in evidence-based practice because it's incredibly practical for busy ward and requires minimal training to master. You are essentially breaking your observation down into 5 specific behavioral indicators: how the patient is breathing, the vocalizations of sound they make, the facial expression, their overall body language, and their consolability. You score each of these 5 categories on a straightforward scale from 0 to 2. A 0 means baseline or normal, while the 2 indicates severe, obvious distress, like a complete rigid body, or loud crying. You add them up, and within a minute, you have a definitive score of out of 10. That final number is incredibly powerful. It translates a subjective feeling of, I think they are in pain, into reliable clinical metrics, providing an exact subjective documentation needed to safely justify and administer analgesia, whether the patient is resting or actively moving. Another excellent evidence-based tool you'll frequently see used on the ward is Abbey Pain Scale, APS, which is validated for patients with late stage of dementia or cognitive impairment who cannot verbalize their distress. It operates with a slightly bigger scope than PAINAD because it prompts clinicians to assess outside of just behavior. It includes physiological changes such as sudden spike in heart rate, altered blood pressures, diaphoresis, as well as physical changes like presence of skin tape, pressure area, or joint contractures. Because it casts a wider clinical net, recent literature suggests that APS can actually be more sensitive at picking up subtle, low-intensity pain signals, meaning a PAINAD might occasionally underestimate a patient true discomfort, but just a quick heads up, because we are the one observing, there is always a chance for a little bit of bias of it. That's why we try to standardize how we use it across the whole team. No matter which skill you end up using, the name of the game is looking for a change in behavior. You really want to zero in on their face, you need to see them doing a horizontal mouth stretch, or parting their lips and dropping their eyebrows. These are statistically proven red flags for high pain. We are even starting to see new AI apps that use facial recognition of this, but your human observation is the core skill. Also, don't forget to chat with your family members. They know the resident best and can tell you when they are acting out of character. Let's step onto away from theory and look at the real case study from the world. Meet Mrs. Gabel. She is an 84 years old non-verbal patient with advanced Alzheimer's. During routine bed-to-chair transfer, she suddenly becomes highly combative. While it's easy to dismiss this as standard dementia agitation, applying the PAINAD scale, it tells a different story. Based on noisy breathing, crying out during hip movement, and constant grimace, physical rigidity, and being completely inconsolable, she scores 9 out of 10. This definitively indicates severe acute pain, perhaps from an undiagnosed fracture or sudden arthritis flare. Our immediate action is to halt the transfer, safely return her to bed, and administer analgesia. After this presentation, your task is to evaluate this exact scenario using the Abbey Pain Scale. The Abbey Pain Scale is broader than PAINAD because it includes psychological and physical changes, making it highly sensitive but also requiring careful teamwork to avoid observer bias. I want you to calculate your score, interpret your result, and see if your conclusion matches the severe pain crisis identification by our PAINAD assessment. To wrap things up today, just remember that asking for verbal pain score isn't going to cut it for our delirious residents. Inadequate assessment can lead to terrible outcomes like prolonged mechanical ventilation in ICU and risk of infections. Get comfortable grabbing the PAINAD or ABS tools so we can catch their pain early and get them the right care. I will also be sharing feedback form after the presentation ends. If you can fill it up and give it back to me, I really appreciate it. Feedback form will help me figure out if the presentation was useful and determine how to improve the session. Finally, we will have a quick quiz after this presentation to assess your understanding of the tools we discussed today. These are some references to the articles we used in this presentation. Thank you, everyone.